Good morning. My name is Megan. I'm one of the chief residents at Sinai. Today I have the pleasure of introducing our grand round speaker, Dr. Raymond Benza. Dr. Benza is the System Director for Pulmonary Vascular Diseases at Mount Sinai Heart and is a professor of medicine at the Icahn School of Medicine. He's a fellow of the American College of Physicians, the American Heart Association, Council on Clinical Cardiology, the American College of Chest Physicians, and the American College of Cardiology. He is a diplomat of the American Board of Internal Medicine with certification in subspecialties of cardiovascular diseases and advanced heart failure and transplantation. Dr. Benza currently holds administrative positions in the Pulmonary Vascular Research Institute and the International Society of Heart and Lung Transplantation, and is the former treasurer of that society. He also served on President Barack Obama's Advisory Committee on Organ Transplantation in the Health Resources and Services Administration for 4 years, and he was knighted in 2015 by His Royal Highness Vittorio Emanuele of Italy for his philanthropic work in patients with pulmonary arterial hypertension. He was admitted to the Association of University Cardiologists. He sits on multiple journal editorial committees and is the steering committee chair for several industry trials in PAH. His primary clinical interests are the evaluation and treatment of advanced congestive heart failure, cardiac transplantation, and PAH. He participates in many clinical studies of new therapies for treatment of heart failure, mechanical support, and pulmonary hypertension. Dr. Benza is a funded investigator for the National Institutes of Health and the American Heart Association for his work in PAH, focusing on risk stratification, pharmacogenomics, and new device therapies. So please join me in welcoming Dr. Benza.
Thank you for that kind introduction. It's a real pleasure to lecture here at Mount Sinai. As you know, I'm a new faculty here and love being back teaching with residents and house staff. And so I hope you enjoy today's lecture and hope you find it useful in your clinical practice. So today we're going to talk about the classification, diagnosis, and management of Group 1 pulmonary hypertension. There are many forms of pulmonary hypertension, and I am more than happy to come back and lecture on these different subtypes throughout the year. So keep me in mind when you have some empty slots. These are my disclosures. Well, to begin a talk on pulmonary hypertension, you really have to understand the 10 commandments of PH, and these are outlined here. And today what we're going to be doing is focusing on a subset of these commandments on Group 1 disease, learning what the definition of pulmonary hypertension is, how to classify it, how to make the right diagnosis, how to apply risk-based treatment management decisions, and finally go over some of the modern therapies that we have for this disease. So let's talk about what's new in terms of the definition of pulmonary hypertension. There have been some significant changes over the last 5 years in what we define as pulmonary hypertension. The definition is based on pure hemodynamics, the pressure in the pulmonary artery. We have decreased the definition of pulmonary hypertension from a mean pulmonary artery pressure of 25 to a mean pulmonary artery pressure of 20. And this is important because in actuality, the normal pressure, mean pressure in the pulmonary artery is actually 14 millimeters of mercury, and that rises with age. But when you get beyond the mean PA pressure of 20 millimeters, the number of events that people who have this pressure experience significantly increases. And so we lowered this pressure in order to capture more people earlier in their disease so that we can get them on appropriate therapy. In addition, in order to define precapillary disease, in which there is a disease distinctly in the pulmonary arterioles, we actually lowered the definition in resistance from a PVR of 3 to a PVR of 2. Again, to capture people very early in the disease, where we can make distinct modifications in their treatment algorithms in order to prevent them from progressing to more severe disease. And there's also been a new definition for pulmonary hypertension at exercise. As you know, when you exercise and you increase cardiac output to the lungs have this amazing capacity to accept that volume by recruiting millions of networks of tiny pulmonary vessels. In pulmonary hypertension, those tiny network of vessels disappear, and so the lungs are able to accept less and less cardiac output at exercise. And so typically, you can increase the liters in your lungs by twofold without changing the pressure in the lungs. That doesn't happen in pulmonary hypertension. When you increase the cardiac output, your pressures will rise proportionally to the amount of output in the lungs. And so the definition of exercise pulmonary hypertension is now determined between the slope of the mean pulmonary artery pressure and the cardiac output. But most important thing is to remember mean PA pressure of 20 and a pulmonary vascular resistance of 2 now defines pulmonary hypertension. So pulmonary hypertension was once thought to be a rare disease, but really, if you look at all forms of pulmonary hypertension, this is really a global epidemic. It affects 1% of the global population, and this will rise to 6% of the global population as people age and exceed the age of 65. No matter whether the disease is in the precapillary component or in the postcapillary component, the mortality that's associated with pulmonary hypertension is directly proportional to the mean pulmonary artery pressure and the pulmonary vascular resistance. And your first question when you identify these people is to really try to find out where the disease is located. Is it in the precapillary vessels? Is it in the postcapillary vessels, the pulmonary veins, or is it in the heart or the lungs? But irrespective of what form of pulmonary hypertension that you have, the end product of this is right heart failure, and right heart failure is what leads to death in patients with pulmonary hypertension. It is not the pressure, it's the response of the right heart to that pressure. So there are 5 general categories of pulmonary hypertension. There's pulmonary arterial hypertension, in which the disease is in the precapillary pulmonary vessels. We have group 2 disease, which is associated with diseases of the left heart. Group 3 disease associated with diseases of the pulmonary parenchyma. Group 4 disease, which is related to obstruction of the pulmonary arteries. And then group 5 disease, which is a multi-component form of pulmonary hypertension. The most important thing is in distinguishing these 5 types of pulmonary hypertension is to identify the trigger. What's actually causing the disease? And we'll go over that in a little bit in subsequent slides. The next question when you see someone with pulmonary hypertension in your clinic is to think, well, which form is the most common? You don't want to always pick the zebras. And knowing the prevalence of the different forms of pulmonary hypertension is very important, because then you can put the more prevalent forms higher in your differential diagnosis and then work down from there. So it's very, very important to understand which forms of these are more prevalent that you'll see. And then lastly, it's really important to accurately diagnose which group of pulmonary hypertension your patient fits in, because the treatments for each of these 5 groups is distinctly different. And if you treat a patient with one form with therapy meant for a second form, you can hurt that patient. So it's very, very important to make sure you correctly classify patients into these 5 different groups. Well, this is how you start your diagnostic algorithm. You really have to understand how to identify pulmonary hypertension because the symptoms and signs of pulmonary hypertension really mimic other much more common respiratory or cardiac diseases. So you have to have a very high index of suspicion when you're seeing a patient in the clinic with unexplained dyspnea, which is the most common symptom that PH patients present with, and think about risk factors. Does this patient have HIV? Does this patient have a connective tissue disease? Something that might propel you to bring pulmonary hypertension to the front of your mind. These are the general signs and symptoms of pulmonary hypertension. The symptoms of one of our lung and cardiac impairment. So dyspnea on exertion is the most common sign. You can see symptoms of exertional chest pain, particularly if someone has severe pulmonary hypertension in which the pulmonary artery enlarges and compresses the left main coronary artery. People can have shortness of breath by compression of the laryngeal nerves. And most often than not, the signs of pulmonary hypertension are the signs of right heart failure. So edema, hepatic congestion, hepatojugular reflux, a loud second heart sound should give you the clue that pulmonary hypertension may exist, peripheral cyanosis, clubbing, looking for telangiectasias, all these things that might give you a hint that this patient may have pulmonary hypertension as the cause of these signs and symptoms. Well, the way you diagnose pulmonary hypertension is you take a patient who has this index of suspicion in your mind and you do an echocardiogram. That is our main screening tool for identifying pulmonary hypertension. And the first step with this is actually looking at the Doppler PA pressures that you see on the echocardiogram. So you're looking at the tricuspid jet velocity. And typically when the TR jet velocity is greater than 2.8 meters per second, this identifies a patient with high pulmonary pressures in the artery. Once you identify the pressure, the next thing you want to do is you want to look at the right heart, and you want to look at the morphology of the right heart. Because this can give you an excellent clue if the pressure you're seeing is either a false positive pressure or if it's really exerting some detrimental effect on the right heart. So when you're looking at the right heart on the echo, you're looking at their dimensions of the right heart, not only the right ventricle, but also the right atrium. Remember, the right atrium is the first chamber that sees this pressure coming back at it from the lungs, and it will be the first chamber to actually enlarge. So right atrial distension, right ventricular enlargement, looking at the relationship between the right ventricle and the left ventricle as the right ventricle gets enlarged. Remember, both ventricles are confined within the pericardial space. So as the right ventricle gets bigger, the left ventricle is going to get squished. So typically you will see a D-shaped left ventricle in patients with pulmonary arterial hypertension. And then lastly, you have to look at function. So the way we look at function, the right ventricle is something called a TAPSE. And because the right ventricle contracts very differently than from the left ventricle, the majority of the contraction of the right ventricle is longitudinal. So TAPSE is actually looking at the difference between the excursion of the base of the right ventricle with the apex, so as it contracts longitudinally. And this is a very unique number that tells you the function of the right heart and can tell you if this pressure is real, if it's really exerting some detrimental effect on the right ventricular architecture. Pericardial effusions are also a very big sign of pulmonary pressure. As the pulmonary pressure increases and the right ventricle enhances and gets larger, remember, everything is constrained within the pericardial space. So the drainage and the emptying into the right ventricle can also get impeded, and you get lymphatic obstruction, which causes these pericardial effusions in PH. So that's another good diagnostic clue that PH may be present. Well, once you've now seen that the pressure is high and that there's some element of right ventricular dysfunction or morphological changes, then you really know that you're cooking here, that you have identified someone who actually has pulmonary hypertension. And then you can go on to the diagnostic algorithm, trying to correctly classify which group this patient then belongs into. And this is really important because the delay in diagnosis of pulmonary hypertension is significant. From a time a patient develops symptoms to a time they actually undergo diagnostic right heart catheterization to correctly classify them usually takes anywhere from 2 to 4 years. Now, this is a rapidly progressive disease. Without therapy, the mean life expectancy is only 2.5 years. So if you're blowing a lot of the time trying to correctly identify what's causing symptoms, you're doing this patient a significant disadvantage. So it's very, very important to try to get people correctly from your suspicion to their diagnostic right heart catheterization, because you can see on the other portion of this slide that over 70% of the patients that we see in clinic now already have advanced symptoms of heart failure. They're already class 3 and 4. And when patients are class 3 and 4, their mortality at 1 year exceeds 60%. So it's really hard to bring these people back from the cliff when they're presenting at such an advanced stage. So having a high index of suspicion, knowing how to use the echocardiogram to correctly identify pH so you can put them through the diagnostic algorithm is critically important. So once you have a great degree of suspicion and detection, you want to start trying to classify patients into one of these 5 groups of pulmonary hypertension. And this is where you use a variety of other algorithms to correctly identify if the main trigger is coming from the heart, the pulmonary arteries, or from the lungs. And so there's a variety of testing that we do in lung assessment, pulmonary function studies, ABGs, chest CTs, and CPET to determine if these people have significant pulmonary parenchymal disease that might characterize them as a group 3 patient, or if they have significant cardiac disease, they have left ventricular dysfunction, systolic or diastolic, left-sided valvular dysfunction that can make them a group 2 patient. So using these diagnostic algorithms is critically important in making the right classification for these patients. And finally, making sure that people don't have obstruction of the pulmonary arteries, or CTEPH is a very important part. So let's go over a little bit about the 5 forms of pulmonary hypertension and try to understand what the individual triggers are for this, because this is really critical for you to make sure that you place people in the right classification scheme. So these are the 5 main groups of pulmonary hypertension. Group 1 is when the disease is located within the pulmonary arteries themselves. There's a familial form of this or a heritable form. There's a large form called idiopathic, in which we don't know what the actual mechanism of action is. And then there's associated group 1 disease that can be related to congenital heart disease, connective tissue disease, and others. And we'll go over that in a little bit more detail later. Group 2 disease is pulmonary hypertension related to problems with the left heart, systolic or diastolic dysfunction or valvular heart disease. Group 3 disease is related to underlying diseases of the pulmonary parenchyma, interstitial fibrosis, bad COPD, sleep apnea. Group 4 disease is related to chronic obstruction of the pulmonary arteries, as we see in chronic pulmonary emboli or even schistosomiasis. And then group 5 disease are those that have multiple mechanisms for causing pulmonary hypertension. The most classic of these is sarcoidosis, in which you can get parenchymal lung disease, you can get primary cardiac disease, and you can get a distinct pulmonary vasculopathy. So group 1 disease is comprised of these particular entities, and I want to go over a few of these because I think they're important. The main trigger for group 1 disease is an actual intrinsic abnormalities of the pulmonary arteries themselves. There is significant endothelial dysfunction in these arteries, which allows disordered growth and regulation of smooth muscle cell activity, which compromises the vessel lumen. So group 1 disease, as I mentioned earlier, can be related to a variety of different things. But if you look at the pie charts here, the majority of the patients that we see with group 1 disease have idiopathic pulmonary arterial hypertension. Now, we don't really know what the main trigger is for this form of the disease, but they have no other risk factors for any other diseases. Many times these people we will later find out to have had somatic mutations that may cause pulmonary hypertension, but this is the largest group that we see. Then followed by connective tissue diseases, which make up at least 20% of what we see, followed by congenital heart disease, most often ASDs and VSDs. But you can see the other common forms are those associated with HIV and portal hypertension, and then drugs and toxins, which we'll go over in a few minutes. So 3 main categories: idiopathic, connective tissue diseases, and congenital heart disease. Now, when you think of heritable disease, 7% of our patients who have group 1 disease have some mutation that is causing this disease, and 70% of those mutations will be in the BMPR2 gene. The BMPR2 gene codes for a surface receptor on smooth muscle cells that acts to keep that smooth muscle cell in check. It prevents it from growing, it prevents it from constricting, and it allows it to undergo apoptosis. So when this receptor is defective, those smooth muscle cells no longer respond to those stimuli, and they grow unchecked. They constrict naturally, and they don't undergo pre-programmed cell death. Drugs and toxins are another huge cause of pulmonary hypertension that we see in the clinic, and I think it's really important to kind of understand some of the mechanisms of these drugs. Diet drugs were the infamous drugs in the 1960s and 70s that caused these. These were amphetamine-based compounds that people took to lose weight. And the likelihood of developing pulmonary hypertension if you took these drugs for more than 6 months was 6 to 1. So extremely potent cause of pulmonary hypertension. There are many other drugs that can do this. Commonly, we see this in oncology. So a lot of the drugs that we use to treat CML with multiple myeloma, amyloidosis, can all cause pulmonary hypertension. So cyclophosphamide, your tyrosine kinase inhibitors, particularly dasatinib, can also cause pulmonary hypertension to a significant degree. Now, the good thing about these oncology-caused pulmonary hypertension is they're reversible if you can identify it and stop the offending agent. There are other drugs on this list that people take over the counter. So you can see St. John's wort is on here, and L-tryptophan. These are common supplements that people will buy in the pharmacy to take care of depression or bowel disorders. We have a huge Asian population in New York, and so this indirubin is a Chinese root that is taken often for bowel disorders and sometimes for ulcerative colitis. And so it's important to understand these drugs so that if you have someone who's coming to you who's being treated for one of these diseases and on one of these offending drugs, you can appropriately identify them. As I mentioned, connective tissue disease is the next largest group of patients, or group 1 that we see. And the largest group of patients are those with lupus. We once thought it was patients with scleroderma, but it's actually, there are so many more patients with lupus than scleroderma that the prevalence of the disease is much higher in that subset. But scleroderma patients are the patients you really have to be very attentive to. 50% of patients with scleroderma will develop pulmonary hypertension in some time of their disease. And so we actually recommend annual risk screening for patients with scleroderma to identify those who will later progress to pulmonary arterial hypertension. Well, there's some other big hits here, including HIV. 1 in 200 patients with HIV will develop pulmonary arterial hypertension, so it's very important to follow these people. Patients with portal hypertension, we have a big liver transplant program here. 20% of patients with portal hypertension referred for liver transplant will have pulmonary arterial hypertension. And if their mean pulmonary artery pressure is greater than 35 going into a liver transplant, their mortality from that procedure is exceptionally high. So identifying those patients and treating them before transplantation is ultimately very important. Group 2 pulmonary hypertension, the main trigger here is an elevated left atrial pressure or elevated pulmonary venous pressure. And this could be seen in a variety of causes, including heart failure, which is the most prevalent form. And this can be either systolic or diastolic heart failure. Valvular heart disease, particularly on the left, either mitral or aortic disease, can cause group 2 pulmonary hypertension. When you look at what the largest majority of patients with group 2 disease are, it's all valvular heart disease in the most cases. And we once thought that mitral stenosis was actually the most common cause of group 2 pulmonary hypertension, but it's now known that mitral insufficiency is actually the largest cause of group 2 pulmonary hypertension that we see. And we see this a lot now in patients now coming in for referrals for mitral clips. We see a lot of them will have group 2 disease. So someone who has systolic or diastolic dysfunction or left-sided valvular disease, if they have pulmonary hypertension under echo, think that that may be the etiologic trigger for this. The key difference in the pathophysiology of group 1 and group 2 disease is that in group 2 disease, you have significant remodeling of the pulmonary veins in addition to the pulmonary arteries. And I want you to remember that fact because that's how we can hurt people by treating them with a pulmonary artery vasodilator if they have this disease that does not touch the pulmonary veins. So to identify pulmonary group 2 disease, you actually have 2 variants. You have isolated postcapillary pulmonary hypertension in which the pressure in the pulmonary artery is directly proportional to the pressure in the left atrium. And this is a very reversible form of pulmonary hypertension, which is really important to identify because you can prevent it from progressing to the more serious form, which is combined precapillary, postcapillary pulmonary hypertension, in which there is now remodeling of the pulmonary veins and arteries. The mortality associated with this latter form of group 2 disease is as significant as the mortality that we see in patients with group 1 disease. So an average life expectancy of only 3 years if they have evolved to this form. And that's why it's really important to capture these people when they're in the isolated postcapillary phase so you can reverse disease and prevent this from progressing. One of the other most important things to remember about group 2 disease is that when you bring these people to the cath lab, the way we identify group 2 disease is they have to have an elevated wedge pressure. So the pulmonary capillary wedge pressure by definition has to be greater than 15. But a lot of these people come to the cath lab and they've been adequately diuresed, and so their pressure may be below 15. And many people mistake these people as having group 1 disease. So if you have someone who you suspect has group 2 disease, particularly if they have risk factors for diastolic dysfunction, which we'll go over shortly, you have to make sure you tell the person in the cath lab you want them to do a fluid challenge to try to provoke that precapillary component from coming out. And it's also very important when you're looking at these people to look at the morphology of the left heart. If you have left atrial dilation, you never see this in group 1 disease. So left atrial dilation in a patient with a normal ejection fraction should make you suspect that they have diastolic dysfunction as the cause of their pulmonary hypertension. And this is why it's so important. When you look at all the people that you will see with pulmonary hypertension that come to your clinic, 7 out of 10 will have group 2 disease. So when I teach residents and fellows with me, you have to prove to me that this patient does not have group 2 disease before we discuss any other subgroup of pulmonary hypertension. That's how common this is. So I want you guys to remember that when you're seeing these patients in clinic. So these are a lot of the risk factors that you'll see for group 2 disease. Group 2 disease, characteristically, patients will have orthopnea and P&D. Group 1 patients will never have that. So orthopnea and P&D in a patient with PH should trigger in your mind that this patient has occult group 2 disease. Obviously, if they have a history of other vascular disease, cardiomyopathies, if they've had a prior CABG in which constriction can cause pulmonary hypertension, are keys that this patient may have group 2 disease. Now, here are the important things I want you to remember, because the patients that we often confuse are the ones who have heart failure preserved ejection fraction. You look at the echo, the LV function looks totally normal. You see an elevated PA pressure, and automatically you're calling it group 1 disease. Well, I want you to understand the risk factors for diastolic dysfunction, and they're shown here. If you have someone who's hypertensive, who's obese, who has diabetes, if they're elderly, particularly women who are older than 60, if they have a history of atrial fibrillation, which we often never see in group 1 disease, if they have sleep apnea, or if they have coronary artery disease, if you have 3 or more of these risk factors in someone who looks like a group 1 disease, don't make that mistake. These are actually group 2 patients masquerading as group 1 patients. These are patients with heart failure preserved ejection fraction. And a great way to try to identify these people is by doing the HFpEF score. So if you have someone with pulmonary hypertension, looks like a group 1 patient, and you calculate the HFpEF score and it's greater than 5, those patients have a greater than 80% chance of having group 2 disease. So try to really be refined when you're looking at these patients who mimic group 1 disease and really do the score and the tests. So group 3 disease, the trigger for this disease is hypoxemia and parenchymal distortion. And so we often see this in people with very bad COPD, usually greater than GOLD class 2, those with severe interstitial lung disease, those with combined interstitial and obstructive disease. In fact, that category is the highest category in which we see group 3 disease, pulmonary hypertension. So when you're seeing someone with COPD and they have pulmonary hypertension on their echo, look at their PFTs. If they have more than GOLD class 2, likely their pulmonary hypertension is related to that underlying lung disease. For restrictive disease, if their total lung capacity on PFTs is less than 70%, those are the patients who really start getting pulmonary hypertension related to interstitial lung disease. And as I mentioned, the most common is a sleep pattern. One of the most prevalent forms, however, of group 3 disease is sleep apnea. And we know there is an epidemic of sleep apnea in the United States because obesity is an epidemic here. So patients with very significant sleep apnea, RDIs greater than 30, if they have low levels of pulmonary hypertension, think that it might be related to their sleep apnea. So again, group 1 disease, the trigger is intrinsic endothelial dysfunction. Group 2 disease, the trigger is a high left atrial pressure. Group 3 disease, the trigger is hypoxemia and parenchymal lung destruction. And finally, group 4 disease, which is another rare form of pulmonary hypertension, is related to obstruction of the pulmonary arterioles. And this can be seen with chronic PTE. Now remember, when you have the chronic forms of pulmonary emboli, these things are no longer thrombus. They have been incorporated within the vasculature themselves. They actually become part of the intima, and they become a fibrotic mass. Now, these fibrotic masses are actually bioreactors. They're not inert fibrous material. There are tons of trapped macrophages within these lesions that elaborate tons of growth factors that when they go downstream from the obstruction, affect the downstream vessels and cause a vasculopathy in them. In addition, when you have a very large proportion of a lung obstructed, blood is going to get shunted to the good lungs. And this overflow phenomenon to the good lungs actually damages the pulmonary vasculature and sets up vasculopathy even in the normal unobstructed lungs. So group 4 disease is really a fascinating disease. And we diagnose this always by getting a VQ scan. So this is one of the basic tests that we do in all patients with pulmonary hypertension. So all patients with PH should always get an echo and a VQ scan. If you can remember that, you'll catch a lot of these people with these diseases. Once we identify multiple areas of perfusion defects, we will often go on to other studies like perfusion CAT scans or pulmonary arteriography, which gives us a really good idea whether these lesions are treatable. And this is important because group 4 disease is the only curable form of pulmonary hypertension that we see. We can cure group 4 disease by doing pulmonary endarterectomy, which is a surgical procedure in which we remove these fibrotic masses from the pulmonary arteries, or we could do balloon pulmonary angioplasty, just like we do in the coronary arteries, and we can cure this disease. So it's really important to understand it. So when you're thinking about a person that you've identified with pulmonary hypertension by echo, classification is key. Think of these key triggers, look at all the diagnostic algorithms that you can to make sure you classify them in the correct way. And it's important that you classify them. And remember that group 1 disease is a disease of exclusion. You must distinguish patients with group 1 disease and non-group 1 disease, particularly groups 2 through 4, by identifying what the trigger is and by looking at those diagnostic algorithms. And these are very important concepts that I want you to remember. You have to think about the efficacy. So what's the trigger? Can you change that trigger with one of the drugs that we have to treat pulmonary hypertension? Can we treat a patient with the drugs that we have for PAH and hurt them? You have to think about that. So the safety of using these drugs indiscriminately, and also what's the cost of that? So let's go over a little bit this. So when you think of efficacy of the drugs that we'll be talking about for group 1 disease, think about whether they're going to help patients with this disease. So if you look at this patient in the upper left corner with severe combined interstitial lung disease and COPD, how is dropping the pulmonary vascular resistance in this patient going to save this patient's life? When you see that amount of disease, it's that disease that is propelling that patient forward, probably not their pulmonary hypertension. So treating a patient with pulmonary hypertension with that is probably not going to be very effective. Similarly, if you have an occluded main pulmonary artery, as you see on the upper right panel, giving this patient a drug to dilate a pulmonary vessel is actually delaying the time for your curative procedure. So you have to think about that before you randomly use these measures. And then obviously someone with left heart disease, for the reasons we'll talk about in the next slide, you can actually hurt these people. So how can using a drug designed for group 1 disease to actually affect the pulmonary artery hurt people in group 2, 3, and 4? Well, if you give a group 2 patient a pulmonary artery vasodilator, I just told you they have occluded veins and they have a left atrial pressure. So if you dilate the pulmonary artery, all you're going to do is increase flow to an obstructed vein into a high left atrial pressure. And what's going to be the consequence of that? It's going to be pulmonary edema. And this is how we see a lot of mistakes come to the clinic. These people come in pulmonary edema because they've been treated inappropriately with group 1 drugs. If you treat someone with severe COPD-related pulmonary hypertension with an oral pulmonary vasodilator, think of what's going to happen. That drug is going to go to every single arteriole in that lung, including the arterioles in which there is no pulmonary parenchyma next to it. And you're going to cause significant VQ mismatch. And what's the trigger for group 3 disease? It's hypoxemia. So in essence, you're activating the trigger that's going to make group 3 disease worse if you treat these patients indiscriminately for a drug meant for group 1 disease. And finally, if you have someone with group 4 disease and you treat these people before sending them to their surgery, you're delaying their chance of cure. So it's very important to make sure that you have the right diagnosis so you don't hurt them by giving them these drugs inappropriately. So these drugs are very, very expensive. Modern therapies for group 1 disease typically cost anywhere from $60,000 to $200,000 a year and can now reach $500,000 with the new drug sotatercept that people are going to be starting to use. So using these drugs in situations where they won't work is going to bust the bank, and we're not going to be able to afford to give the drugs to the people who will really benefit from them. So you remember, using these drugs efficaciously in the right forms of pulmonary hypertension is very, very important. Well, once you now have a rough idea what class these people are, you have to confirm this. And the only way you can confirm this is by doing a right heart catheterization. Every single patient you diagnose with PH, if you're even considering treating them, must have a right heart catheterization to confirm the diagnosis, to make sure you exclude group 2 disease by doing appropriately challenges if necessary, and to make sure that you understand how severe the disease is and how compromised the patient is. So doing the right heart catheterization is not the easiest thing. I know a lot of the residents have done these in the units and they see how we use Swan-Ganz catheters, but you know the Achilles heel of the Swan is actually getting the right wedge pressure. And this can be very tricky in a patient with very elevated pulmonary pressures. So making sure you read the wedge pressure correctly is incredibly important. Now remember, a correctly measured wedge, you should be reading it at end expiration. And that's marked here on the wedge waveform. That's where the correct wedge pressure is. In addition, when you open your balloon, sometimes you'll get the balloon nuzzled into the pulmonary artery and you'll get a dampened wedge. As you see here in the beginning of this form, you see the nice pulmonary waveform, and then you see this dampened pulmonary artery. And many people will mistake this as the wedge. But if you resize this balloon just a little bit and take a little air, you can see now that goes down into the correct wedge pressure. So remember, to get a great wedge, there has to be a decrement between your pulmonary artery diastolic pressure and the wedge. If your pulmonary artery diastolic pressure and wedge sit right on the same plane, that is not a correct wedge. You can see the nice decrement here between the pulmonary artery diastolic and the wedge. So make sure you get a good wedge and you scrutinize it. So the summary for this first part of the talk is as follows. We have a hemodynamic definition of pulmonary hypertension, which has changed in order for us to get patients screened early and bring them into treatment better. There are 5 main groups of pulmonary hypertension, each with individual triggers, and identifying the main trigger is the best way to classify them. Group 1 disease is a disease of exclusion. You must prove that a patient doesn't have the more prevalent forms of pulmonary hypertension, particularly Group 2 and Group 3, before you line someone to Group 1. And a right heart catheterization is always indicated before you have any thoughts of starting patients on a therapy for this drug, and remember to scrutinize the wedge. So let's talk a little bit about the management of pulmonary hypertension. We're going to focus today on pharmacotherapies and risk-based managements and save interventional and surgical therapies for a different talk. So this is, as I mentioned, the mortality associated with Group 1 disease. As you can see, it's a very deadly disease. Now, in the last 2 decades, we have made significant improvements to the life expectancy of patients with pulmonary hypertension. We've moved from life expectancy of 2.5 years now to almost 7 years. So we've tripled the life expectancy. But if you remember what I mentioned earlier, that Group 1 disease is primarily a disease of young, middle-aged women. Adding 7 additional years to a young woman's life is clearly not enough. We have to do much better in the drugs that we're developing for pulmonary hypertension and the way we're managing them. And so in order to improve this survival curve now, we have to rely on different changes in management style, which is risk-based management, and also on new drug development, which we'll go into. So how do we treat pulmonary hypertension? Currently, there's no cure. Our pH therapies can markedly improve the symptoms and slow down the clinical deterioration of this disease, but most patients will ultimately require transplantation. The management is very complex and involves using a range of treatment options, including general measures, conventional supportive therapy, which we'll go over, advanced therapy, which are PH-specific therapy, which we'll review, and then finally surgical therapy. So what's the general care for someone with Group 1 disease? Avoiding pregnancy is an absolute majority. Remember, many of these are young to middle-aged women in the prime of their lives. The mortality associated with pregnancy with someone with Group 1 disease is in excess of 30%, with an incredibly high fetal mortality too. So contraception is a big thing that we talk about our young women with this disease, and we really hammer this in as we see them as not to get pregnant. And remember, many of the drugs that we treat pulmonary hypertension with are teratogenic to the fetus. So avoiding pregnancy is key. Making sure your patients are always immunized. Anything that can make a PH patient fall off the cliff, you have to avoid. And respiratory diseases are one of the most common ways that PH patients get triggered and get hospitalized. So make sure they get their immunizations, particularly for influenza and COVID. And make sure that patients with severe PH, you teach them to minimize Valsalva maneuvers. So if they're bearing down the strain in the bathroom, or if they're coughing very large, remember, what does this do to your systemic pressure? It lowers your systemic pressure. And if you lower your systemic pressure below your pulmonary pressure, these patients are going to have syncope. So patients with very severe pulmonary hypertension, it's important to coach them about minimizing vagal maneuvers. Oxygen therapy is very, very important. Remember, hypoxemia is the trigger for group 3 disease, but also in patients with group 1 disease, the response of low oxygen levels to the pulmonary vessels is one of vasoconstriction. So avoiding hypoxemia and hypercapnia, which is also a very potent vasoconstrictor, is very, very important. So we often will do nocturnal oximetry in our patients to make sure that we have them adequately oxygenated at night. Diuretics are very key for treating right heart failure. Remember, if you have an enlarged right ventricle, it's going to affect the way the left ventricle fills. So decompressing the right ventricle with appropriate diuretics is a very important part of the treatment parameter for patients with pulmonary hypertension or right heart failure. Calcium antagonists were the first drugs that we had to treat pulmonary arterial hypertension. And these drugs were life-saving in a small minority of patients with this disease. Now, in the new therapy for PH, we use calcium antagonists very sparingly because we found out through the ages that only 5% of our patients are responsive to these drugs. And typically, these are patients who still have a lot of intrinsic vasoreactivity to the pulmonary arteries. So when we take a patient to the cath lab and diagnose them with group 1 disease, we will also often do a nitric oxide challenge in the cath lab to see if these patients still have a very reactive pulmonary vessel. And if they do, you can get off treating them with a very inexpensive calcium antagonist. But the likelihood of them having this robust response, which is defined here by a drop in mean pressure less than 40 by at least 10 millimeters of mercury with a normal cardiac output, these are the only patients that should be treated with calcium antagonists for PH. And this is just a nice video of someone in the cath lab that I took that was giving a nitric oxide challenge. And you can see as I give nitric oxide, what happens to the response to the pulmonary vessels. This is an immediate response that you see with nitric oxide. So again, minimum patients can respond to calcium antagonists, but if you've identified them, it's a very cheap therapy. So let's go into some of the PH-specific therapies for group 1 disease. We really categorize these drugs into 2 different forms now. We are major vasodilators, and then we have our vasoremodelers. The majority of the drugs that we have right now are mainly vasodilators. They dilate the pulmonary arteries and allow a drop in resistance. The remodelers are all the new medicines that are coming out to treat pulmonary hypertension. These are the drugs that directly act on the artery to enhance smooth muscle cell apoptosis, to repress smooth muscle cell proliferation, and to repress fibroblast expansion too. So now when we look at treatment for group 1 disease, we're usually looking at a balance between our vasodilators and our remodelers, and we'll talk about these drugs now. So this is a very complicated pathway of all the main pathways that we use to treat pulmonary arterial hypertension or group 1 disease, and I'll try to go through these with you in a little bit of detail. Our first main pathway were the first drugs that we had to treat this disease are prostacyclins. Patients with group 1 disease do not make prostacyclins, and they have defective receptors for prostacyclins. Prostacyclins act by working on a very specific receptor on smooth muscle cells called the IP receptor, which increases levels of cyclic AMP. And cyclic AMP does every good thing to a smooth muscle cell that you want it to. It makes it dilate, it makes it undergo pre-programmed cell death, and it prevents it from proliferating. So prostacyclin analogs like epoprostenol, treprostinol, iloprost are one of our biggest armamentariums to treat this disease. We actually now have selective agonists to the IP receptor, which we'll go over, called selexipag, that activates this pathway also. Our next pathway that we make use of is the nitric oxide pathway. Patients with pulmonary hypertension are deficient in nitric oxide. For some reason, their endothelial cells do not produce this chemical anymore. And so enhancing responsiveness to nitric oxide or preventing what you have breakdown is very important. Now remember what nitric oxide does to smooth muscle cells, it actually activates cyclic GMP. And cyclic GMP does the exact same thing that cyclic AMP does to the smooth muscle cells. It prevents them from constricting, makes them undergo pre-programmed cell death, and prevents them from proliferating. So enhancing the activity of the nitric oxide receptors, like drugs like riosequat would actually activate guanylate cyclase can really improve pulmonary hypertension. And using PDE5 inhibitors, remember the PDE5 enzyme is the enzyme that induces the breakdown of cyclic GMP. So inhibiting that enzyme with tadalafil or sildenafil can markedly improve patients with group 1 disease. The last system that we make use of the endothelin pathway. Now, the endothelin 1 is the most potent vasoconstrictor known to mankind. And the lung has a plethora of endothelin receptors on it, both A and B receptors. Now, the pathology of group 1 disease is mostly run through the endothelin A receptor. When endothelin binds to this receptor, it makes smooth muscle cells constrict, it prevents them from dying, and makes them proliferate. So blocking this receptor with endothelin antagonists like bosentan or mazatentan or ambrisentan can markedly improve the vasoreactivity of that particular vessel. Now, the last pathway, which is the newest pathway, the first of the remodeling drugs that we see, is a drug called sotatercept. And what sotatercept does is it blocks the ligands that bind to the ALK and the Actria receptor. Now, this is a receptor that's aligned with that BMPR2 receptor that I told you about earlier. The BMPR2 receptor is the good one, and these receptors are the bad ones. Now, what happens in group 1 disease is you have an underexpression of the BMPR2 receptor. So all the ligands go to the bad receptor and activate that bad receptor and make those smooth muscle cells go crazy. What sotatercept does is it actually binds to the ligands that will block that receptor and prevent that receptor from being activated. And this drug is a very, very potent remodel of the pulmonary vasculature. We've seen significant drops in resistance with this drug and significant improvement in clinical outcome. So this is the first of our antiproliferative drugs. So what do all these drugs do for us? This is what PAH drugs do for our patients. They improve the NYHA class, they improve their 6-minute walk distance, they reduces their natriuretic peptide levels, meaning that the right ventricle is now being appropriately offloaded. They improve quality of life, importantly, and most importantly, they improve composites of clinical worsening, particularly hospitalization and worsening of functional class. Not many of our drugs will actually, in isolation, approve death, with the exception of the prostacyclins. But the rest of these morbidity events are equally important. These are the common endothelin antagonists that we use. We have 3 of them, bosentan, ambrisentan, and mazatentan. Ambrisentan and mazatentan are the only ones that we use now because they more specifically antagonize the A receptor. And one of the most common effects of the endothelin antagonists are liver function abnormalities, which bosentan did in about 15% of the cases. Ambrisentan and mazatentan no longer affect the LFTs. So these are the ones that we use. Ambrisentan is given once daily, and so is mazatentan. These are the PDE5 inhibitors that we commonly use, sildenafil and tadalafil. They work exactly the same, and they're equally efficacious. The big difference is that tadalafil, you can get away giving them once a day, and sildenafil, you had to give 3 times a day. So medical compliance is very important when you're using these drugs. The only other thing you remember with tadalafil is that it's excreted renally, and so if you have renal insufficiency, you have to reduce your dose of tadalafil. Riociguat is one of the other special drugs that activate guanylate cyclase and increase nitric oxide. This is a very cool drug because it works in 2 different ways. One, it enhances the binding of nitric oxide to guanylate cyclase, and then also separately activates guanylate cyclase independently. So you get a ton of cyclic AMP when you use this drug, riociguat, and it's one of the most potent drugs that we have. We use it starting at low doses and we titrate it gradually. The reason we do this is because it can also dilate the systemic vasculature. And we do not want that typically in patients with PH. We want a very robust systemic pressure in these patients. So you have to be very careful when you're using these. The prostacyclins are our mainstay of therapy. These are the drugs that get people back from the cliff the quickest. They are the most potent pulmonary vasodilator that we can use. There are 2 forms, epoprostenol and treprostinol. We typically will use treprostinol because it has a longer half-life than epoprostenol, which is in minutes to seconds. So you can imagine if you had a PH patient taking epoprostenol, which is a continuous infusion, and they get disconnected from that, they lose the effect within seconds. So treprostinol has a half-life of 4 to 5 hours, so if people become disconnected from their infusion pumps, they don't have rebound pulmonary hypertension. So prostacyclins can be given parenterally, either IV, subcutaneously, oral, or by inhalation. So they're a really great drug that we can use in a variety of different forms. Most often than not, we would use parenteral prostacyclins, particularly in patients who first come into the hospital because they are often class 3 and 4, as I showed you before. And these are the drugs that we can use to really bring people back. These drugs are administered through a permanent line that you place in the subclavian vein, and people have to wear a continual infusion pump in order to use this. So it is somewhat of a problem with their quality of life. And you have to be really careful of their infusion ports because remember, systemic infections in someone with pulmonary hypertension that causes their systemic pressure to fall can be very detrimental in someone with pulmonary hypertension. The major side effects of prostacyclins are all in the GI compartment. It can cause nausea, vomiting, profound diarrhea. You can see significant thrombocytopenia with these drugs because it affects the clotting cascade. So you got to be very careful when you use these medications. The subcutaneous form really eliminates the issue with line infections and can be given parenterally 24 hours a day, just like the IV forms. But the sub-Q forms can cause a lot of pain at the infusion sites, and that's our major limitation with using it subcutaneously. The inhalational forms have really expanded our use of these drugs because it's very, very simple to use. Our first forms of these inhalational drugs were given by these very large devices, and these were very inconvenient for the patient to use. In addition, because they were aerosolized, a lot of the drug was actually swallowed instead of inhaled, and so the efficacy with these two initial products was very tiny. But we kind of subsequently moved away from these larger pump size to these meter dose inhalers, which have been really a life-saving change for our patients, and it's really been revolutionizing. People love these drugs. They wear these little inhalers in their pockets, and they can puff on these things 3 to 4 times a day to get the necessary doses of prostacyclins in a very efficacious manner. And you can titrate these drugs ultimately. So inhalations, there's no maximum dose that we can do with this, which gives us a lot of opportunity to use these drugs with a lot of efficacy. But remember, they cause the same side effects as the parenteral forms. And this is just an example of the newest inhaler that we have for treprostinil. Tiny, it looks like a little whistle patients can use. We also have oral forms of prostacyclins, and this drug was really pivotal in several randomized controlled studies and done all the favorable things that we wanted to do. And it comes in a variety of different dosage forms. Unfortunately, oral treprostinil, oral prostacyclins are very difficult for a patient to handle. It causes a lot of gastrointestinal side effects, a lot of nausea, a lot of diarrhea. These drugs have to be taken with food. And so it's very difficult to often get these people to the right doses with these oral preparations. But there is no maximum dose that you can use with this. So again, it's ultimately titratable. Selexipag, as I mentioned, is one of the IP receptor agonists. So as opposed to increasing the amount of prostacyclin, this is actually binding to the receptor directly and activating it. And Selexipag is one of our very big drugs in this armamentarium. It's also given orally. It's given up to twice a day, and it has to be titrated to a dose of at least 800 micrograms BID in order for this drug to be efficacious. It has less side effects than the oral prostacyclins because it only binds to the IP receptor. And we feel that many of the side effects from the other prostacyclins are because they bind to the EP receptor on the smooth muscle cells of the gastrointestinal tract. So this drug is a little bit better tolerated than the oral forms of prostacyclins. So those are the basic vasodilators that we have. So the new armamentarium that's coming out for group 1 disease are really our vasoremodeling drugs. And they really make use of all the new pathways that we have identified in pulmonary hypertension, whether it's from the extracellular matrix to dysregulated angiogenesis, to improving mitochondrial function in the right ventricle, to other vasoactive inhibitors and growth factors. And these are some of the new drugs that are coming down the pipeline. Dichloroacetate or ranolazine are drugs that markedly improve mitochondrial metabolism, particularly in the right ventricle. So these are drugs that we're using to enhance right ventricular activity in patients with very bad pulmonary hypertension. As I mentioned, we have drugs now that are targeting inflammation because just like atherosclerosis, pulmonary hypertension is a vascular disease and inflammation is very important. So we have drugs that are modulating cytokines and the NRF2 pathway known here. And then we have other clinical trials that are modifying other signaling pathways, the estrogen pathway, the PDGF pathway, and augmenting BMPR2 signaling, as we mentioned earlier. This is the drug sotatercept. This has just come to market within the last month here in the United States, and it's really going to be a revolutionary drug for treating group 2 disease by activating the BMPR2 receptor and minimizing the effect on that adverse receptor that I mentioned earlier. This drug is given subcutaneously 1 time a month, so it's actually very convenient for the patient to use, and it's delivered directly to their home. It's used just like you would use Wegovy or one of those medications. Inhaled seralutinib is a tyrosine kinase inhibitor. So remember, I told you earlier that tyrosine kinase inhibitors actually can cause pulmonary hypertension. Well, this is a very pleomorphic group of drugs, and some of these drugs can actually be used to treat pulmonary hypertension. Seralutinib is one of the first drugs that we have that's in an inhalation form that's in a phase 3 trial to treat this disease. And it is also inhibited by one of these small meter-dose inhalers. So this is our current armamentarium. We have now over 13 approved products for treating this disease, which is a lot different than 1993 when I started, when we had only calcium antagonists. So it's been a real pleasure to see this progress to this state and form. We are getting a little short on time, so what I'm going to do is wrap up this talk just talking a little bit about how we use these drugs. We use a multimodality approach to determine a patient's level of risk by looking at a variety of different demographic algorithms, clinical imaging to determine if a patient is a high, intermediate, or low risk of dying from this disease. And we use these calculators that actually was key in developing, which has the most important parameters that we follow patients with this disease with. And by using these scoring systems, we can identify people who are at a high risk of death, which is defined as greater than a 10% mortality range in a year, or low risk, defined as a less than 5% risk of mortality. So when we identify a patient with group 1 disease, we will actually use these scoring systems to segregate them into 3 risk categories. And based on their risk categories, that's how we tell which of these drugs to use in sequential patterns. Once patients been on the drugs for 3 or 4 months, we do another risk stratification using these calculators, and again, augment therapy based on their continued level of risk. We see patients in clinic often. So depending upon their level of risk, we will see patients every 6 weeks to those who are low risk to once yearly. All of our algorithms are based on their level of risk, and these are the type of testing that we do to calculate our scores. So the goal of risk-based therapy is to make our patients low risk. We want them to have a less than 5% mortality. So you can see this is a process in which we continually add medications to these various drug schemata. So end-stage PAH, as I mentioned, most of these drugs are not curative. They prevent progression. They make our patients live longer, but the only cure for pulmonary hypertension is lung transplantation. And early referral to lung transplantation is key because the biggest attrition after lung transplantation is in the first 3 months after the procedure. And this is usually because people come to us in extremis before undergoing their lung transplantation. So getting all high-risk patients referred for lung transplantation is really one of our goals of therapy. And we have a great lung transplant program here at Mount Sinai with really significant 5-year survival rates. So I would encourage you, if you see patients, to make sure that we get them seen by the transplant team early in the course of their disease. So in summary, PH remains a relentless progressive disease. We have newer medications that really have provided a new leash on life to these patients. We use these drugs in combination and usually by risk-based management, and a referral to a PH center is really recommended because the complexity of this disease. This is our program here. It's really a multidisciplinary program that involves many different disciplines: cardiology, pulmonary, adult congenital heart disease, and thoracic surgery. We have inpatient and outpatient consult services here. We're expanding our services. We'll have our separate inpatient consultation service in the future. And if you see any patients with this disease, this is how you can contact us, or just remember my name and look me up on email if you have any questions. So I hope this was helpful and at least for a good introductory talk on this disease. And obviously I'm here and always open for questions or emails or texts. So please feel free to contact me, and thank you for your attention this morning.
If not, I think we can thank Dr. Benza for a great review. Thank you very much.
Thank you.